I want to welcome all of you. My name is Sergio Aguilar-Gaxiola, and I'm a professor at the University of California at Davis. And particularly welcome to our community, Our Health, which is a town hall series to share ideas about health prevention and interventions that have impact in our communities. Just to let you know that we have a Spanish interpretation, and I want to acknowledge our two interpreters, Carmen Alanis and Lorenzo Lopez, who are going to be with us throughout the meeting. And Crystal, if you can please show the Mentimeter slide. I would invite you, all of you, this is important for us. If you can possibly, can you put the slides back on? Great, thank you so much, Crystal. If you can, using the QR code, answer this question. This is a word cloud about what comes to your mind when you think about meaningful community engagement. And we're going to wait just a few moments for hopefully you helping us answer that question. This is an important piece for us. Great.
So before you show a condo, look at what those require.
This is populating. That's great. Thank you so much for your participation. Great. So we are gonna I'm gonna introduce now my dear friend and colleague, Dr. Lloyd Michener. As you can see on the slides, this describes briefly Lloyd's remarkable background. He's an emeritus professor of family medicine and community health at Duke. And he has been engaged with communities across the U.S. He's the co-founder of the Community Engagement Steering Committee for the NIH CTSA program and served on the National Institute of Medicine Committee on Integrating Primary Care and Public Health. Also the work group on Assessing Meaningful Community Engagement, which Aisha Williams is going to be presenting here. And also he is one of the co-chairs for the Principles of Community Engagement and is the leader of the Practical Playbook and chairs the board of the Foundation for Health Leadership and Innovation with over 3,000 North Carolina community partners. It is my pleasure to introduce and leave you with Lloyd. Lloyd?
Thank you, Sergio, and thank you everyone for joining this event. I'm going to be, maybe ringleader would be the term, trying to keep this all coordinated, because we're going to practice what we preach. This is a session on community engagement, and I like the title, How People, Stories, and Data Advance Health Equity. And we've got some wonderful speakers, and we also recognize there's deep expertise among those participating. So the way we're going to do this is actually have a wonderful opening session by Asia Williams, and I'll introduce her in a second, talking about the work of the National Academies. And then we have three panelists. I'll introduce them as we come, and who will talk about how their work and the National Academy's work and the partnerships with community intersect and what it's meant for them. And then about half the time of this session is actually for this group discussion, interaction, to hear your contributions about what we may have left out and what you would add, and to ask questions and really look for how we advance this work together with, for, and by our communities. So it's going to be, I hope, really interactive. At the end, I'll try to summarize some of the themes that we've heard, and then we'll end on time. That is one of the traditions of the sessions. So let me go ahead and introduce our keynote, who's talk about the work I think many of us know, but you may not know the background and some of the deep information on that. So Asia's going to describe that. And for those of you who don't have the pleasure of knowing Asia, she's a program officer at the National Academy of Medicine Leadership Consortium Collaboration for a Learning Health System, which is a wonderful long title, but I like the collaboration in learning. She leads the Culture, Inclusion, and Equity Action Collaborative, each word of which actually matters, which has really been focusing on facilitating meaningful engagement. What does meaningful mean? And building trust with individuals and communities served by health and healthcare systems. Her background is she went to Drexel University, where she studied health management and policy, received her MPH, worked at Thomas Jefferson Hospital, has a bachelor's in human services from Northeastern. But Asia is really about her interest in understanding, promoting, and helping meaningful patient, family, and community engagement in developing and implementing equitable and sustainable health and healthcare programs and policies. So, and I've had the joy of working with her, as many of us have. So Asia, let's turn it over to you and you take it away. By the way, I should add, as she gears up, we'll have time for a few clarifying questions at the end of each session, and then we'll hold off the group discussion because we got a lot of time for that at the end. So Asia, over to you.
Thank you so much, Lloyd, and thank you everyone for having me here today. And before I start, I just want to emphasize that there are many, many people behind the Assessing Meaningful Community Engagement project, including my team and former team members at the NAM, our organizing committee, some of whom are on this call, and of course our project funders who've just been tremendous allies and partners in this challenging but very rewarding work. So for my time up here at the virtual mic, I'm just going to provide some background on the project, like Lloyd mentioned, and talk about the need for the development of our conceptual model. And afterward, I also wanted to spend some time talking about how the other resources developed within our suite complement and can be used with the model as a part of your measurement strategy. So next slide, please. Great, and then diving into the project background. So the project started with the understanding that although there has been a widespread acknowledgement on the importance of engaging communities to influence and impact the health and well-being of people, there remain several rate-limiting factors to progress, including limited knowledge of and access to tools to facilitate and assess engagement and ensure communities feel engaged. So we really needed a strategy and resources to measure engagement and identify its impact. Next slide, please. So thus the goal for this project was to create a menu of effective, evidence-based, and community-engaged indicators and metrics to measure meaningful community engagement in a wide range of settings, to track and guide progress and shape how health and healthcare programs and policies are developed, implemented, and overseen with an emphasis on those most in need. Next slide, please. So recognizing that engagement can take place in many contexts and bring people together through varied structures, the intended audiences for this project really include anyone who wants to measure engagement to ensure that it's meaningful and impactful, including but not limited to the groups listed here. And within this list, I just want to flag that we understand that, of course, health does not occur primarily within the traditional walls of a hospital or healthcare system, which is why we make sure to include systems that impact health outcomes within this list. including housing, transportation, where you learn, eat, play, and pray. Next slide, please. These are the smiling faces of our organizing committee. And really, like I said, this group has just been extremely influential in helping to support this work, and is comprised of leaders who are so diverse.
If they say no, then we just keep rolling.
Background, expertise, and experiences. Next slide, please. So together, the organizing committee identified foundational standards for our work, and I won't go through all of the ones listed here, but want to highlight a few that will pop up quite a bit as I go through the rest of the slides. So for example, it's really important to have a model that was flexible, that embedded equity throughout, presented a range of options, and communicated the really dynamic and transformative nature of engagement. Next slide, please. And so this graphic just depicts the connection between all the project outputs. So starting with the conceptual model and the impact stories and assessment instruments, and then our various dissemination tools, which includes our website, our guide to using the resources, and a forthcoming report on our process and a framework for advancing meaningful engagement with the resources. Next slide, please. And so we'll jump right into the conceptual model. So can we go to the next slide, actually? Thank you. Like I was saying at the beginning of this project, our organizing committee members really felt that there was a need for a conceptual model. And the committee studied several to fit that need, but they felt that the current models were missing elements of importance to this project, including those identified in our foundational standards. So with these various needs in mind, we set out to develop a new model. Next slide, please. So these are our community leaders from the larger organizing committee group who were just really instrumental in the development of a conceptual model to fit the context of the project. Next slide, please. And as a part of that development process, we engaged them in a lot of discussion, but it wasn't just us asking them, what they wanted, but having really iterative conversations about what should be included and the language we would be using to convey that. So asking, does this word capture your feelings, thoughts, and experiences? Can you see your voice in this model? And here are just some of the quotes from those really insightful conversations. Next slide, please. So these are the 8 prototypes of the model we went through. There were a few other previous design attempts that thankfully didn't make it to this slide. Luckily, we were able to get design support from Kim Irwin and Tomoko Ichikawa at the IIT Institute of Design, who were just really able to bring our vision, especially the community leaders' vision, to life. So in these prototypes, you'll see that each visual was optimized for a primary goal, and an ongoing challenge was distinguishing visually the engagement process itself from the engagement. This was a consistent theme across these images, and a turning point for us was really the development of model number 6. So what distinguishes this design is that engagement was centered in the middle of the model. Next slide, please. So that theme continued into the final version of our model. So as you can see at the center, of course, we have community engagement. Next slide, please. For the next layer, our core principles are the foundational characteristics and values of engagement that should be present from the beginning of the process, such as trust and inclusivity and so on. Next slide, please. So from that point, there are specific outcomes to be assessed to help partnerships understand whether meaningful community engagement is taking place in the form of our 4 domains. So these measurable outcomes or domains are grouped into the categories: strengthened partnerships and alliances, expanded knowledge, improved health and healthcare programs and policies, and thriving communities. And as a subset of the domains, we have the indicators, so the text in italics, which are what we believe people should measure or evaluate to understand their baseline. and what changes need to occur to move forward and improve. And you'll see that there are a few places where there's some overlap between the principles and indicators. For instance, you'll see trust pop up quite a bit, and this just really emphasizes the importance of measuring this trait and how much this trait really permeates throughout the model. Next slide, please. For the last layer of the conceptual model, the organizing committee also really wanted to emphasize that these various factors are not occurring in a vacuum. You must consider alignment with drivers of health, or the social determinants of health, the relevant political, historical, and racial context, and how this all affects community engagement efforts. So the idea is that as you move through the model, a feedback loop is created and reflected through the arrows in the outer circle that move from community engagement, the principles and the domains, to these contextual factors, and that a new level of improvement occurs as the loop continues, ultimately bringing us closer to equity through transformed systems of health. Next slide, please. So in thinking about the ways to use the conceptual model, it's really important to emphasize that this model is meant to be a complementary and living one that will only improve over time as end users continue to adapt it to fit their unique community contexts, priorities, and needs. So in using the model, we really encourage people to sit down with the people in your collaborative or communities, determine which core principles, domains, and indicators matter most to you. The idea isn't to focus on all at once, and then connect the model to the other resources in the suite. So with that in mind, I'll move on to the other resources, starting with the impact stories. Next slide, please. And next slide, thank you. So as reflected in the model, we know that community engagement is not a single event, goal, or checkbox. It's a complex and dynamic process that changes across time and location. And we know it can be hard to get started when you're just looking at a model or thinking about, I guess, community engagement abstractly. So the organizing committee really wanted to share real stories of community engagement told by individuals involved in the work to demonstrate different approaches to engagement and how it's evaluated, including kind of the secret sauce for different groups that made their engagement meaningful and impactful. Next slide, please. So for the process, our committee initially shared about 20 potential stories from their varied work and experiences, and revised the list with a careful, thoughtful eye to elevate compelling stories of what's possible when you do and assess meaningful engagement. So it's just a very brief overview of the 7 final impact stories, which you can see represent a wide range of locations and communities, organization types, health topics, and engagement levels. Next slide, please. So we worked with the same human-centered designer who helped us with the conceptual model and held interviews with storytellers and community members so that they could share more about the process and impact of their engagement work in their own words. So here's just an example of some of the core components of each story using the It Matters impact story. We wanted to make sure the stories were accessible, contextual, authentic, and just really demonstrated clear examples of meaningful engagement to inspire action. Next slide, please. So for ways to use the impact stories, we encourage you to listen to and reflect on the stories of groups that resemble yours. Learn about what the storytellers did to engage and the lessons they learned along the way, thinking about what you could pull from these lessons and what you might even do differently. And in that process, think about the stories that you want to share about your own engagement and outcomes and who you want to share them with, for example, funders. And last, map these stories to the outcomes of the model. Next slide, please. And here's just an example of the mapping we did for each impact story to the core principles and outcomes of the conceptual model using It Matters again. So as you can see, they started with core principles of engagement that is co-created, culturally centered, grounded in trust and co-equal, and experienced improvements in all 4 domains, from strengthened partnerships and alliances all the way to thriving communities. It's really important to note that none of the stories highlight all the outcomes because, like I mentioned earlier, when I was talking about the ways for using the model, they're not meant to be all or nothing. Rather, the model acts as a menu of items, and the groups in the story selected from that menu identified elements that were important to their partnership and work. Next slide, please. So for our last resource, we have the assessment instruments. Next slide, thank you. We knew we needed specific questions that connected to the model elements to help end users assess whether they've been able to achieve the outcomes they've prioritized and understand what are the potential areas for improvement. So we identified and developed summaries for 28 assessment instruments. Next slide, please. I won't get into the nitty-gritty details of our literature review process to find the 28 assessment instruments, but I will say that once we conducted the review of the relevant literature, we ended up with over 1,000 sources that we knew we wanted to prioritize a smaller subset of articles and instruments from to create a manageable set of measures we could ultimately crosswalk back to our model to identify that alignment we knew would be of use to people. And after discussing different prioritization criteria with the committee, we decided eventually on prioritizing instruments that first engaged communities in their development, evaluation, or implementation, and second, underwent some kind of psychometric property testing, so validity or reliability testing. And with these criteria, we were trying to emphasize the importance of ensuring the active presence of communities in measure development and also tackle this common misperception that community engagement lacks scientific rigor. Next slide, please. So to make these instruments and their alignment with the model more accessible, we developed summaries that present information from the articles that our committee felt were important for audiences to know in deciding what instrument or instruments would work best for them. So here are some teeny tiny screenshots of the summaries. And just to point out some key elements of all of them, we share the alignment of each instrument question to the model domains and indicators in a table in the left image, recognizing, of course, that others might interpret this alignment differently and crosswalk these questions elsewhere in the model. In the right image, you'll see that we also paraphrase the context of the instrument development, purpose, use, and other summary information in these summaries. Next slide, please. So for ways to use the assessment instruments, similar to the impact stories, we encourage looking at the summaries that align with your unique context, including setting, language, community composition, and goals. This information is available in the summaries wherever we could find it. And then once you identify your instrument or instruments, you can use the exact questions shared. But of course, we also encourage modifying and tweaking the questions or even creating new ones to complement the ones available. And last, you could also create your own model based on the outcomes you are looking at, so that you can always visually see what it is you're measuring using the assessment instrument questions. Next slide, please. So I just quickly wanted to share a screenshot from our webpage dedicated to the assessment instruments. And I can share, of course, web pages for all the resources, but this shows how we've organized the assessment instruments to support your exploration and navigation. So you can view the instruments in alphabetical order, or maybe you're interested and exploring the instruments that align with all 4 outcomes of the model, or, according to place of instrument use, available language translations, or that have specific psychometric properties. So it's all organized for you to explore. Next slide, please. And so I'm going to end here with what we see as the way forward. So for the way forward, we really ask that you reconsider what engagement looks like and think about the impact that you want, the process, and really using measurement as a tool, because what gets measured gets done. So it's important to be proactive and measure what matters the most, which is meaningful community engagement. Thank you.
Thank you, Asia. You just summarized in less than 20 minutes several years of work by so many people, and really about people, stories, and data, and how that's central to community engagement and achieving health equity. So thank you so much for this work and for the work going forward. For folks who've joined since we started, let me just remind you that there's a globe button at the bottom of your screen. So if English is not your primary language, please feel free to click on that and select Spanish. We are doing interpretation of the verbal comments, questions, and as we go. So please use that, and do ask questions in the chat. We're going to be monitoring that because there are about 90 people online. So we also will try to look for waving hands, but with that many people, we can't see everybody. So please use the chat. And there have been some questions coming up in the chat already, including, will the slides be available? And the answer is yes. They'll be posted as a PDF link at the end of the meeting. And will the recording be available? And again, yes. And that's the link that will be used for that is also in the chat. If you have any problems with that, please let us know. And then, because Asia did such a great job, we actually have time for a question or two. If you have a clarifying question, we have lots of time at the end for discussion because there's so much wisdom in this group. But has anybody got a question to clarify with Asia? Please put it in the chat. That's probably the safest way, because otherwise we may miss your hand waving. Going once. I'm from North Carolina, and I can't quite do the patter of a tobacco salesman, which is almost undesirable. Going once, going twice. Here we go. Thank you. How engaged was the community in this process? Asia.
Sure, yes. So, and I will preface this by saying I wasn't there at the very beginning, but I do know a lot about the history about this project from when I wasn't there. So in the beginning, it's really interesting. We actually had, the organizing committee. I kept talking about this committee, and it was originally a steering committee filled with academic, policy, research experts. And then we had some community leaders. And at some point, there was some reflection on, practicing what we preach, because the numbers really just weren't stacking up against each other. So we actually doubled the amount of community leaders within the project, and we ended up combining the community leaders with the steering committee to create what I refer to now as the organizing committee, because really everyone had, important experiences and expertise that were, meant to be incorporated in the same way throughout this project. So that was a really important turning point for us. And I know that we have some people on the line who could definitely maybe share more about their experiences being a part of the organizing committee, but definitely I'd say that we engage them in every step of the way, every important decision to be made about the resources and just, the project in total. So I'll stop there.
And let me suggest that, because there are actually a number of other questions that we'll hold those over for the group discussion. These are great questions, and frankly, the discussion is the point of the meeting. And Asia's comment about practicing what we preach is near and dear to all of us. So we'll come back to those questions. Please keep asking them. We're noting them and we'll return to them as we go. But at this point, I'd like to pivot actually to our first panelist, who's going to start talking actually about some of the things people are asking about questions about how's this actually being used and applied in the community settings. So one of the members of the organizing committee is Debra Oto-Kent. And I get to introduce her. She's the founder and executive director of the Health Education Council. And her primary areas of interest include coalition building among diverse stakeholders, resident engagement, and reducing health equities among underserved communities. She's been working for many years on developing model programs focusing on addressing the underlying social drivers of health to reduce disparities from preventable causes of health. And the organization she leads has been named a nonprofit of the year by the California State Legislature 3 times, 2016, 2021, 2023. She received her MPH from the UCLA School of Public Health. And Debra, we'll turn it over to you. And guys, again, put your questions in the chat as we go.
Thank you, Lloyd, for your introduction and for your leadership in promoting community engagement over the years. Also, just want to thank Sergio Aguilar-Gaxiola and his team for decades and decades of authentic community engagement work and for pulling together this meeting. And finally, thank you, Asia, for shepherding the important work of NAM and the Assessing Community Engagement Organizing Committee. It's been a years-long journey and is so relevant. I've been involved in public health and doing public health community-based work for almost 4 decades now. And I think that our time in the realization that authentic community engagement and inclusion to its highest standard is more important than ever now. And what I'm seeing is that folks from many, many different sectors are understanding the important impact that they have in meaningful community engagement. And so this effort to document and to look at measurement, how we measure it, is so important. In fact, this week, I'm meeting with the executive director of a regional air quality resources board who reached out and said, how do we engage community better? How do we improve how we are reaching communities, particularly low-income communities, and how do we measure that? So this work that is focused on health and healthcare in the research community, I think is potentially be very, very far-reaching. Asia also mentioned impact stories as part of the array of tools that are part of the Assessing Community Engagement process and toolkit and materials that are available. And the impact stories are designed to highlight some of the key aspects of the core principles or outcomes that are sought through authentic community engagement. And the Health Education Council were really honored and so pleased to be selected as one of those impact stories that are highlighted in the National Academy of Medicine toolkit. So I'd like to share the walkability story, impact story, which highlights some of the principles of the model. And while that's kind of being keyed up, I'm going to share that this project has been one that we have been working on for 8 years now.
I'm Debra Oto-Kent, and I'm Executive Director of the Health Education Council, a nonprofit organization based in the Sacramento region in Northern California. This was a $60,000 planning grant from RWJ as part of the Invest Health initiative that was supposed to last a year, I think. Our proposal focused around food security. We submitted the application for the city of Roseville. And our work in that city was really in the lowest income neighborhoods. The California Department of Health Services data showed that that neighborhood was a food desert. And food was really the issue. I mean, it was a documented food desert. When our team got together, we wanted to re-vet the data. Like, we wanted to validate, is food and food security the highest need? And so when we got funded, we formed a
a 5-member multi-sector team that was going to really embark on this work.
The first thing we did is lay the intention out that community engagement and hearing voices of folks not traditionally involved around the table was fundamental to our project. We just talked to people and we kept hearing, for example, the name Lupita. Well, we wanted to meet Lupita, and Lupita ended up hosting a backyard barbecue. It turned into a larger event in her backyard. We went to after-school programs and met with parents as they were walking to pick up their kids.
We really cast a very wide net. We wanted to just start with a new slate. Like, we obviously talked about food, but we just said, like, what's nearest and dearest? Like, when you think about health, what do you think about? What comes to mind? And food was not the highest priority. What came up was safety, connection, walkability. And so basically we pivoted and changed our approach. What consistently came up was the neighborhood park. The park was not safe, homelessness, drug use, drug paraphernalia, lighting, treescaping.
And that is causing lack of utilization of the park.
The one thing that was food related is many of the moms said,
there's grocery stores that are close enough for us to walk, and we like walking. But what we really need is safer routes to walk. We need a couple of sidewalks where they're not. We need on and off ramps where we could push our stroller or navigate our cart a little bit easier. A lot of the solutions that residents came up with were pretty low-hanging fruit. You know, we started with treescaping.
The city found some community development block grant money, immediately improved the sidewalks, so there was increased walkability. Parks and Rec started implementing programs. Kaiser Permanente gave us 2 park improvement grants. We built a classroom on the park, an outdoor learning center.
One of our partners with the city said, you know, there's this effort to reduce greenhouse gases. And part of that is retrofitting current lighting of city streets and local parks to LED lighting. That's funding that's coming down, and that's maybe an opportunity. The magic that kind of happened was they were the first park to get their lighting improved.
The only other amenity was a very, very, 100-year-old pool.
But it was old, it needed repair. The priority for that was elevated because the community was saying, this is a valued asset in our community. It is worthy of being prioritized for investment. And so the renovation happened. It recently reopened. They're having a celebration.
There was some very, very visible changes.
So is our work still involved with food and food security? Yes, it is. It's just broader. Quality of life and well-being, like all of these issues are highly, highly interconnected. It is the responsibility of the research and academic community to think differently, to engage differently, to ask differently, to listen differently. It's not enough to do the traditional, we posted a flyer and nobody came. It is talking to that one person and saying, you live in this neighborhood. What do you think is the best way to listen to other folks? Would you be willing to talk to us? Like, we have to hold ourselves and others accountable for what does engagement really mean. This is a new day for engagement. And if we don't begin to look at it and embrace it and operationalize differently, we're going to continue to see the same kind of outcomes.
If we could go to the next slide. The impact story was developed in 2022. So I'll share a little bit of follow-up of what's been happening on the initiative since then.
It's Jess Mandak. I am one of the physical therapists here at the Pain Center. I have been.
What I wanted to share is that over the last 3 decades, the Health Education Council was founded in 1991. Foundational to all of our initiatives have been 2 strategies. One is that we've long recognized that most of health happens outside of the doctor's office, and it happens where communities live and work and play, pray, shop, learn, and grow old. And what we know is that it will take many, many sectors coming together in a collective impact approach to improve health outcomes, particularly for low-income communities, and to create the thriving conditions that are vital for people to live healthy, thriving lives. So one is cross-sector collaboration and working with other sectors. One of those groups that we have foundationally always worked with is residents and people who live in neighborhoods. Our resident engagement efforts are asset-based, focused on historically excluded communities, because we believe that people who are closest to issues are closest to solutions, but often they're not asked or engaged. Next slide, please. This I think illustrates the approach that we took in the impact story that you just viewed, and also many of our other program initiatives. And I'll start on the left here, that most of our projects and initiatives are started by digging into data. And I think many of you can relate to, we have a lot of data in public health around inequities, around health disparities, high-level data that may review an unequal burden of health issues or conditions in certain communities. In the case of the impact story, it was higher rates of obesity, higher rates of diabetes. Another example in a project we are working on now was higher rates of heart disease, higher number of visits, disproportionate visits to emergency rooms for heart disease related conditions like hypertension. So digging into data is often where we start, and it's generally a lot of high level data. The second step we think is important is to take that high level data and listen to residents. Listen to residents without assumptions, without only talking about the data, but understanding from the resident perspective, and those most impacted are the subject, if you will, of that data, to what that really means to them. In the initiative that we have current now about elevated heart disease rates, we held listening sessions and met with community activators and influencers. And we asked people, when you think about your neighborhood, who are the people that come to mind? We gathered a group of 12 to 15 resident activators or influencers. And during that meeting, the group of residents identified 260 assets to leverage. What are things happening in our neighborhood? What are the things you're involved with? Who are groups that are already meeting at churches, community groups, women group? How do we activate them in service of improving health and health outcomes? This information helps us to set direction or approach for what are interventions. And in the case of the impact story, it really helped us pivot and change our direction from what we thought was trying to bring a full service grocery store into the neighborhood to address obesity and the fact that it was a food desert, to pivoting to addressing putting in curb cuts so folks could walk to the grocery stores, or increasing community gatherings around things that they were asking for. So this listening has always led us to set a direction that is aligning with what we're hearing, or changing direction when we were off course. The next step around building trust through action, I noticed somebody in the Mentimeter at the beginning of the session mentioned follow through as an essential element. We believe that listening is only credible and important if it is truly listened to and there is action that is followed up. And almost every time we have found that things that we may not even be thinking about leads to, as Asia said in her presentation, inspired action. We believe that listening leads to small inspired action that is responsive to community. So what are some of those things we've done? In other communities, we hear, we need another neighborhood cleanup day. There is trash that is gathering up in this certain area. These are the low-hanging fruit that can be acted on and lead to visible changes in neighborhoods. And finally, we always feel that it's important to listen deeply again. And then I'll go back in my example about heart disease, what we found is that the most important idea and issue that residents were bringing up was about social connection. It was about, how do we connect with our neighbors more? We don't talk to our neighbors. How do we activate public spaces, parks, walking trails, places where people can gather to provide places for connection? And we are deeply involved in that work to really think through with residents, how do we act on your suggestions and build trust through action, and listen again to make sure that what's happening in neighborhoods are being responsive to what we're hearing. How do we create partnership with residents in order to create change? Next slide, please. So I've been thinking a lot about impact, and in the National Academy of Medicine ACEs work, we talked about impact stories, and we talked about inspired action. And I've been thinking about, what is the change that we are really seeking to achieve? And my organization has, through the years, have been funded through grants and contracts, and we're always asked to document our impact and to write reports and to talk about sustainability and how we're going to sustain our efforts. And so in the example of the impact story and the park, we have been keeping from the very beginning resources and investments that have been going into the neighborhood. I mentioned we started with a $60,000 grant. Today, the investment in the neighborhood is over $12 million. That impact story was done at the end of 2022. In 2023, the City Council voted to invest $9.5 million to completely reimagine and renovate the park and the 100-year-old swimming pool. We circle back to the model, and that took a lot of listening with residents to reimagine that park and that swimming pool so their footprint is in that park. So we've been collecting sort of measures of impact, but somebody asked me, what is it you're really trying to improve? This is a book, A Park for Everyone, tells the story of Nina, a little girl whose grandmother lives next to the park and wanted to play in the park and was wondering why her grandmother wouldn't let her play in that park because it was unsafe. This is a story really of Nina's empowerment, because she spoke up and she told people her vision of that park. And I am so excited that the city just broke ground on reimagining that park a month ago. And by the end of the year, that park will be reimagined. Next slide. Likewise, we are following this model of listening, learning, building trust through action, and listening again. This is a book of Nina and her grandmother again, on an initiative we're working on around reducing cultural stigma of talking about mental health. And what we've learned through our Mente Sana Vida Sana initiative, our Peers Helping Peers mental health programs, around Nina's journey of learning about why her grandmother seems lonely and why her grandmother feels like she's not connecting with her friends enough. And after being involved, I think, in public health for so long, I'm trying to push myself to really think about, what is it that we're really trying to impact? And what we're trying to impact, in my mind, are the lives of health, of the Ninas, of the grandmothers, of families who live in underserved neighborhoods that we served. Next slide, please. So a few things just about what I've learned over the decades. I believe that trust, many of us have mentioned trust. I think Asia mentions it twice in the model. Trust is the secret sauce of community engagement. I used to work with the late Bishop Sherwood Carthen in our area. And he was the one who told me, he said, Debbie, trust is the secret sauce. If you want to build relationship, you build a relationship by building a history of doing things. You build a history by showing up, by attending, and that builds relationship, and that builds trust. It is a circle: trust, history, relationship. In terms of community engagement, what matters? The messenger matters, the approach matters, how you enter and exit and maintain relationship matters. Listening without an agenda. Often we go into communities with our own agenda, what our grant was funded to do, and we close ourselves off to what we really need to hear to advance overall health in a community, recognizing that all of it's interconnected, and yet sometimes we look at things in a very siloed approach. Listening without an agenda, acting on what is heard, pivoting if that's necessary. Meeting people where they're at, where health happens, where people live, work, play, pray, shop, learn, and grow old. Recognizing that change, listening and responding is incremental, looking for visible change, and providing evidence of listening to community is important. The mayor of the city of Roseville told me during our project, she said, Debbie, I had somebody stop me in the grocery store and thank me for having the trash picked up in the neighborhood, of improving the lighting in the neighborhood. These are visible, incremental things that are evidence of listening. We believe that community engagement has to be asset-based. We talk so much about needs in communities, but to recognize the rich assets that all neighborhoods have and resilience space. We know that many underserved communities, ethnic communities, have tremendous amount of resilience. How do we lift that? And we also believe that people want to contribute to and sustain what they help to build.
Deborah, thank you. Oh, thank you so much. Yay. That was just inspiring. There is a question, and I don't know if Cynthia Salas can unmute.
Sure.
Please go ahead.
Thank you. First of all, thank you for everything that's being provided today. It is so timely for some of the things I'm doing, my part of the world. But my question a question that I would like to ask is, how do we ensure that everyday residents are part of this process? Many times well-intended community leaders or representatives tend to capitalize on making the decisions for the community. They obviously bring value and feedback, but sometimes it's not necessarily the whole picture. So I just wanted to ask if you navigated any of that, and if so, what lessons were learned there in terms of how to better engage the everyday resident, and it's still including our community leaders, but not necessarily letting them be the ones that lead the charge for the entire community.
Yeah, what an excellent question. You know, I feel like we as kind of conveners and organizers, you know, have to hold ourselves accountable and keep asking that question: is who hasn't been around the table? Who needs to be around the table? Whose voice are we not hearing? And, you know, we in the city of Roseville and other cities that we work with, one of the things they started is they wanted to activate the neighborhood associations in the core neighborhoods, and there were no active neighborhood associations. And after about a year, we started to invite people who spoke Spanish exclusively. And we had a couple of people come, a mother and a grandmother and their child come, and we had interpreters. And we asked, why is it you've never come to a neighborhood association meeting? They said, nobody's ever invited me. I would have come, but I haven't been invited. And so we work obviously with a lot of, you know, gatekeepers, if you will, or representatives. But we also feel like there is a tremendous richness in hearing from others. And it's a different, you know, we just have to dig deeper. We try to hold ourselves accountable to do this, what I've always called snowball networking, right? Around who are those people? Can we invite that person? How can we make our meetings, our convenings, our focus groups, whatever we're going to call them, more accessible?
Thank you for the question, and what a lovely answer, Deborah. Thank you so much. And I think we're going to come back to this question and theme as we go into the group discussion. In fact, I think we're going to come to it in our next comment from our panelist. So let me thank Deborah. We'll come back to her and the whole group. And let me introduce the group to Miriam Hernandez, who graduated from the Autonomous University of Baja California in Mexicali and its School of Medicine, and worked as a general physician in Tijuana and Baja for 10 years, serving a low-income community. She got her bachelor degree in medical science in the US, and then for 14 years worked in Providence Health and Services as development and training manager for the Latino Health Promoter Program, a really wonderful way of form of community engagement. And then for 7 years, and has been working as the workforce development manager of Visión y Compromiso, and has been really participating in different advisory groups on the community health promoter program in multiple sectors, from HPV, e-health, cervical cancer, autism, diabetes. So really a wonderful expert in the use of Promotoras as links and connectors in community engagement with their strengths of and from the community. So Miriam, over to you.
Thank you, Lloyd, and thank you, Dr. Sergio and the team for inviting us to be part of this event and to recognize the role of the community health workers and promotoras, as part of the team and working together with our communities, the role that they are doing in our communities, in engaged our communities, and they know very well our communities, and they give us the opportunity to work with them and work with our community. Then for me, could you, the next slide, please? Okay. I want to share with you why is very important community engagement for me. As an immigrant, as an immigrant physician, I think when I was working in Tijuana, Baja California, I was working with my community. We create a model where physician, nurse, and promotora were working together for our community. Not only the clinical part, but also the prevention and education. We work all the time with low-income communities in Tijuana, and they were very involved in the process. Our community members not only get the physical exam and that's it, they understand very well the diseases that they had and how they can prevent diseases. This is why when I came to this country, it was so difficult for me to understand the health system for this country. And I was thinking, if it's difficult for me to understand, how difficult could be for my community, my Latino community, or the communities from different countries, no? Because their experience is different from this country. Then I was looking for different organizations that they were working with or together with our community and see how they can have access to this health system, how they can understand this health system, how they can prevent diseases, how they can educate for diseases. Then another way that I can answer this question is through, as a part of the community-based organization member. I think a community-based organization can work very close with our communities because when they organize or planning a specific project, they need to know our community first. Then these projects can be the solution or another option to resolve the needs of our community. Then our community can get involved in their own process. And it's true, promotoras and community-based organization, promotoras and CHWs, the way that these community-based organizations are working together in our community and get involved the community, be proactive, be responsible for their health. No, not only the physician or nurses, psychologists are responsible for the health of others. It's my responsibility. I am responsible for my health, and then our members of the community needs to understand that. Then I think one of the way that we can get involved our community, the way that we can engage our community is working together with CHWs and Promotoras in different sectors and different areas, not only health, or for me, if we define health, is the balance between the physical, mental, emotional, social, spiritual component of the human being. Then if we understand that, we know that Promotoras and CHWs can work in different aspects of the human being. Then I want to share with you the model that Visión y Compromiso, but also Esperanza Community Health Incorporation that is here in Los Angeles, and Latino Health Access, another organization that is working with Promotoras in Orange County, get together and understand how CHWs and Promotoras work in our community. Why this model is so effective engaging our community. And the way that we create this model is we put in the center CHWs and Promotoras. And we believe that through the process that they pass through, for example, trainings, their own stories, their own situations that they pass as members of the community, they transform themselves. When they transform themselves, then they transform their families and then their communities. But they start with them, okay? Through the different trainings and different concepts that they start to learn, something happened in themselves. Then they start to experience this transformation, but for them it's not enough. It's not enough because they are leaders of our communities. They are natural leaders in our communities. Then for them it's not enough to only to have this transformation and that's it. Because I passed through this situation and I get this information, then Promotoras and CHW start to share this information with others and they start with their families because they are the people that are close to them. They start with the husband, with the kids, and they start this process with them too. But then it's not enough for them. Then they need to continue with our community. They start moving in our community. They start sharing with our community. They start to let them know, do you know what? It's something that you can do for your diabetes. It's something that you can do for your health or for your mental health. Then they start to share with the members of the community and start the transformation in our community, that development of our community. And this is a beautiful process that they are doing because they are natural leaders in our community. Then they understand, they know that they are not physicians, they know that they are not nurses or psychologists. They know that I am for this process, I have the knowledge, the experience that I can share with my family and with my community. But how they are working in our community, this is another important part, no? Why the Promotora and CHWs are so successful in our community? How is the way that they are working with our community and get our community involved in their own process? Could you pass the next slide? Thank you. Then we believe in this model, the community transformational model. And we believe that it is the way that CHWs and Promotores are working in our community. and why it's so successful, that work that they are doing in our community. First of all, they are the bridge between our organization and our community, between hospital and patient, between physicians and patients. They are the bridge between them because they provide information. But for me, it's more than that. It's more than they provide information and that's it. Because I think when we have, for example, an event, Promotoras and CSW not only pass flyers and invite the community to go to the health fair. No, it's not enough for them to pass the flyer and that's it. Promotoras and CSWs take the opportunity to educate our members of the community. If in this event, in this health fair, is going to have the screening for diabetes, the glucose level, no, then they start to share with our members of our community about diabetes. What is diabetes? What is the glucose? What happened in my body? Then they educate our members of the community. They help our members of the community to be aware about the disease and how they can prevent and how they can know more and more about the disease and control the disease. But also in this component, in the bridge component, it's in two ways. They can bring the information from the hospital to the community or the organization to the community, but also they can bring the information from the community to the organization. This is why it's in two ways, no? Then, for example, if we have working in a research project, it will be magnificent to have this kind of model and working with CSWs and promotoras, because in this way, the investigator want to have information for our community, but also the community needs to know information about the investigator. Then it's in two ways how this is working and why this is why it's so effective. And in this component, the community start to know more and more about the promotora and CSW, but also about the organization and the clinic and the hospital and the center, in any local situations where promotoras and CSWs are working with. The other component, and for me it's amazing, this component, is how promotoras and CSW build trusting relationship with the members of the community. They have something that they can work together with our members of the community, and then they can start to see promotoras and CSWs as a trusting person. They believe in them. They know that they are doing everything for them, for our members of the community. Then they start to build this trusting relationship that I believe this is so important for us as an organization, as an institution, as a universities. It's very important to build this trusting relationship with our community. In this case, our community can get involved, can get part of the process, can get part of the team, and they can work together with us, with investigators, with physicians, with nurses, with social workers. If we can build this trusting relationship, the members of the community can get involved. And this is why promotoras and CSW are doing their work in an effective way. And there is this very successful work that they are doing in our community. And the third component is not enough to give information, educate our members of the community to build this trusting relationship, but also it's important how we can motivate our members of the community to get involved in their own process. And this is very important, no? Because then our patients It's not only, oh, the promoter is going to help me to bring from my home to the hospital, or she is going to make the appointment for the mammogram. No, this member of the community can be proactive, can be part of the process, and not only the person, also the family and the community. Promotoras and CSW motivate our community to participate in their own process. They cannot depend on the promotora. They can be proactive in their own process. Okay. Then for us or for physicians, this is so important. Then the patient can get involved in their disease, can be responsible for their disease. In research project, we want the community to participate because sometimes they don't trust in the research project. No, then how we can get them involved in the process through this model, the community transformational model. That is the way that CSWs and promotoras are working in our community. I think for me, this is the most important part of my presentation because it's the way that we can engage our community to be part of the process. Working together with CSWs and promotoras, it would be wonderful to get our community involved in any process. Okay. The next slide, please. Okay. Another example that I want to share with you is this project that we work together with Dr. Gaxiola and his team, and also with the University of Michigan and Florida. Is the Advancing Research Best Practice for CSWs and promotoras. When Dr. Gaxiola invited us to be part of this project as a community-based organization, for me, it was a wonderful idea because and the most important for me, it was the way that we can get promotoras and CSW as a part of the team, as a part of the research team. They can get this training, but not only to get the information for them and that's it. It was more than that. How CSWs and promotoras can be part of the team together, working together with the investigator and with the whole process in the research project. And I think CSWs and promotoras can do a wonderful job with that. No? Then when we start working together for this project, first of all, they design a curriculum for promotoras and CSW to get this training and know more and more about the research process, but how community can get involved with participation of the community. And this is another important part for this project. No? We create this training culturally and linguistically appropriate for training in research best practice for community work, for CSWs and promotoras, and how they can get the information easily. And one of the most, one of the steps that we put attention was how this curriculum can have a popular education methodology, because it's the way the promotoras and CSW can understand better, and also our community when they know more that different topics or they attend to different trainings and we use popular education methodology, is easy for them to understand and make the changes. But also another important part for this training was how we can increase the capacity and ability for CSWs and promotoras into the workforce, and how they can be part of the team and be part of the of the whole team working together, no? Then
we're going to need to wrap up in just a minute.
okay, perfect. I almost done. Thank you. Then I want to share with you these two resources that are available. One is the this one that is talking about the Promotora model, and you can understand better the role of the Promotora and CHW. And the other one is the workforce priorities that we developing with a group of organizations to know more about what are the needs for the Promotoras and CHW to incorporate into the workforce. Thank you.
Miriam, thank you for all your wonderful work and contributions. And let me see if there are any questions for you. By the way, the link to the reports is in the chat. And there's some wonderful comments about how important this work is, Miriam. So you've really resonated with the group. Any questions? You can put it in the chat, or we'll try it and spot you if you raise your hand. Going once. Going twice. Okay, we will come back, I promise. Let's go to our third speaker. I feel a little silly introducing because my guess is almost everybody knows him. But in case anybody doesn't know Sergio, Sergio Aguilar-Gaxiola is a professor of clinical internal medicine at School of Medicine, University of California, Davis, founding director of the Center for Reducing Health Disparities, and director of the Community Engagement Program for the UC Davis Clinical Translation Science Center. In addition to that, he's a member of the NIH National Advisory Council for Advancing Translational Sciences and a member of the National Advisory Council for the Substance Abuse and Mental Health Administration, their Center for Mental Health Services. If that weren't enough, he sits on several World Health Organization and Pan American Health Organizations advisory groups and is a member of the Executive Committee of WHO's World Mental Health Survey Consortium. He's been co-chair of the steering committee of the National Academy of Medicine group on assessing meaningful community engagement, which we've been talking about, and also, most impressively, co-chaired and development of the principles of community engagement, second edition, and oversaw that translation to Spanish, and now the third edition. By the way, the second edition has been downloaded more than 10 million times. So Sergio, I think, has been a driving force in all this work and one of the reasons we're all here together today. So Sergio, over to you.
Thank you so much. Lloyd, can you hear me? Excellent. Okay. Well, let me tell you how I'm very inspired by the presentations that Asia, Debbie, and Miriam did. What a wonderful information on something that I know that is close to your heart, Lloyd, and certainly close to my heart, which is meaningful community engagement. Next, I'm going to share with you the, it took me years to really settle for what my North Star is. And it is unequivocally to serve the underserved. This is what we do at the Center for Reducing Health Disparities. This is, we are focused on solutions to advancing health equity, as simple as that. And community engagement is the key component in order to do that. And I want to also emphasize that building trust and becoming trustworthy organization are front and center in community engagement. I think that this has come across in the information that Asia and Debbie and Miriam presented. So next, this is a question that has guided me for decades. And that is it possible to advance health and mental health equity in historically underserved populations through community-based approaches? And I had been very much involved in this quest for a long time. And what I can share with you is that right now, for example, our center is funded for over 10 projects, and all of them have a community engagement component. And my answer to this, based on evidence, is that yes, this is possible. And I want to share next. I want to share this, this distinction that really captured the work that we did for about 8 years, multi-year project in which we combine community engagement, meaningful community engagement, with the cultural linguistically appropriate services standards to transform the system of care in Solano County. This was a countywide experience that we had. And I'm very, very humble, but also very happy that the Association for American Medical Colleges gave us a second prize for the Innovations that Bolster Community Trust in Science Award for what you see there, Solano County Interdisciplinary Collaboration and Cultural Transformation Model. This is an innovation project, once again, that we had the wonderful opportunity to implement in California. I want to also emphasize that and bring to your attention that the second prize was given to my dear friend and colleague, Linda Cutler, for HealthStreet, a model that she developed and that she has been implementing for decades, actually. And this town hall platform, our community, our health, is pretty much associated with HealthStreet as well. Next. Next. Just what I just mentioned to you, that the answer, based on the evidence that we collected in this particular project. We have other projects in which we have also demonstrated that health equity can be advanced. And I want to emphasize again how key meaningful community engagement is. Next slide, Crystal, please. So one of the key questions that I've been asked over and over again is, how do you do meaningful community engaged work? And Lloyd mentioned in when he was introducing me, the work that he and I and many others did on the second edition of the CDC Principles of Community Engagement. And those are available both in English and Spanish. It has been widely disseminated in English-speaking countries and Spanish-speaking countries. I'm still very impacted by knowing that it has been downloaded 10 million times. And so it is, if you haven't seen it, I would strongly recommend that you do. Take a look at it. And actually, the third edition is about to be released by the CDC as well. It's ready, but it's going through the motions at the CDC. And I'm very proud to say that the foreword for the third edition was written by the DHHS Secretary of Health, Javier Becerra. It's a beautiful, beautiful write-up that he did. So I would encourage you to keep it in your radar. And when it's released, we will be widely announcing that it has been released. Next. One of the things that we did for the third edition is to add a 10th principle. The first edition that was released in 1997, second edition 2011, it was comprised of the 9 principles that you see there. But in the third edition, we added principle 10, which is on trustworthiness. Trustworthiness and trust building are key, not only concepts, are key ingredients, key elements for meaningful community engagement, as I mentioned to you. Next. So just to share with you, this is kind of a sneak preview of what is in the third edition. It's a little bit of information about Principle 10, and that is the recognition that trustworthiness is essential to forming effective partnerships and through building relationships based on empathy, honesty, respect, and humility. It deepens the commitment and hopefully a long-term commitment that any one of us who do community engagement, embrace. It is important to think in terms of long-term. And this is a process. I have heard Lloyd mention that this is a journey. It's not the destination, because it is a living process. It is dynamic. And, as we have seen it over and over again. The other thing that is important and is required actually for trustworthiness is multi-directional communication. I'm emphasizing there bi-directional because I want to bring to your attention that it is not just one way, but actually it is multiple ways, and we need to really be ready to listen attentively when we engage with communities about what matters to them, as I emphasize there. This is absolutely necessary. Next slide. So I'm coming back to what Asia presented already. I have been following community engagement for decades. Actually, my training on my PhDs in clinical and community psychology, and I have been following the field for a long time. And in the work that we have been doing with Asia and her team and the National Academy of Medicine, we reviewed a little over 20 leading community engagement models. And I'm going to be objective here to tell you that this is the best model that I have seen for many reasons. And Asia already provided some insights as to what is in the model that makes it so encompassing. But one of the things that I want to connect the dots along with you is the centrality of community engagement guided by several principles like building trust, and how it is connected with transforming systems for health and advancing health equity. That is one of the way in which I consider this model is that it's a roadmap. If you are interested in advancing health and mental health equity, this can give you insights, not only insights, but also how to measure the process. And so I would strongly recommend that you take a look at it seriously. And also to tell Asia, she mentioned about the case studies of the model. I can tell you that I have seen the model being utilized in so many different ways, from training, training students at all levels, from medical students and residents, fellows, postdocs, undergrads, to also including the model in grant applications, as we have done it on several times already, and also in publications. Lloyd and I recently submitted a chapter for a wonderful book on mental health equity, and we included the model in the chapter as well. Next. So the next phase for me, going back to serving the underserved, is that for too long, I think we had been operating, the health systems have been operating under the waiting mode that I call, and that is here we are, as a clinic, a community health center, a medical center, hospital. Come to us when you are in need of services. But usually, when that happens, it is too late, because many people have been studying, for example, Latinos and other historically underserved populations, and they don't come for services until they are falling apart. We actually had been studying the barriers of access to care for decades, so we know which are those, and that leads me to the alternative, which is the seeking mode, that we need to go to them. And next, and here, yes, here, the idea is to intervene, go to where people are at, where they live, where they work, and where they congregate, and provide services on the spot at the point of need. So, and intervene before the symptoms appear, or when they start, and preserve normal function for as long as possible. So what we need is a paradigmatic shift. And I'm going to mention something that I hope that bring a smile to you. A paradigmatic shift, because shift happens. Next. So we have been working on this project that we call Digital Health Equity, funded by HRSA. And this is exactly what we are doing in this project, that we go where people are at, using, collaborating with digital health navigators. So we go to, for example, where farm workers are, where they live, where they work, where they congregate, carnicerias, grocery stores, you name it. And we offer services on the spot, right there. And we are working with two fairly qualified health centers, as you can see there, WellSpace and AMPLA, which are the largest FQHCs in WellSpace in Sacramento County, and AMPLA Health in the Sacramento Valley, which comprises 6 counties, rural counties, and in which they serve a very high proportion of farm workers, which is a population that we are very committed to serve. Next. Just to illustrate a little bit, this is when we launched the Digital Health Equity Project, which is one of the projects that we are working on. This is in Richland, in Yuba City, at a migrant housing center. This happened back in October 8th, and we were present there. And what you can see in the slide is on your left-hand side at the bottom picture, Jose Flores, who is our digital health navigator, providing 2 preventive health screenings. One is blood pressure, measuring blood pressure, and also a little bit later, to the same persons, he offered a screening for depression using the PHQ-9. And we have been doing this for quite some time now. And I'm extremely excited about this. And we are also doing body mass index, and we're hoping to expand to glycemia, blood sugar, etc. Next. So to finish, often people ask me, well, can you share with us what are some of the main lessons that you have learned? And I have boiled down, many lessons, many of them that I have learned with Lloyd, from whom I have learned so much with his wide experience on meaningful community engagement as well. So I'm boiling down these to the 4 S's. One is that if you really are engaged, are committed to doing meaningful community engagement, you have to be sincere, next, simple, next, straightforward, and next, to shut up, to listen and listen and listen attentively. But we need to learn how to listen to those that we are intending. We are this. We are serving. And Lloyd, I'm stopping here and looking forward for the next few minutes.
Sergio, yay, thank you again. Folks, we're going to go to a group discussion in just a minute, but first, any particular clarifying questions for Sergio? And you can wave your hand, raise your hand, put it in the chat. I see, well said, Sergio. If not, we're actually going to change what we planned, because as this has been going on, it's clear there's a lot of expertise on this group. And so Sergio's last point was shut up and listen. And in fact, one of the key points that we've talked about throughout this process is the importance of listening. So what I'd invite you to do, and really would appreciate if you do, again, put in the chat, raise your hand function, or wave your hands. We're going to be looking for that. What I'd like to know is what struck you, and what did we leave out? What would you add to what we didn't explore enough or explain enough? So what really resonated, or what did we miss? And please help us all learn from each other. Comments and questions, additions, folks. And please don't be shy. Oh, that was too hard a question. Okay, I'll ask our panelists. Guys, all resonated. Thank you, Cynthia. And I would add, missing a student voice, especially our, I don't know what TAY. Cynthia, would you unmute and explain?
Sure, it's our transitional age youth, the 16 to 25 age bracket. And I think that it's very important. As some of the folks here know, I transitioned out of healthcare into education. But I'm here today because we're entering, I'm very fortunate to lead an initiative for community schools, healthcare being a big component of it. And even when I was at the county agencies, healthcare system, our youth usually get what we as adults or community leaders design for them, but that the 4 S's, as Dr. Gaxiola mentioned, needs to really be resonated and implemented with our TAY or our youth. Given that from where I'm standing at our angle, they're usually the ones that don't provide the most input, and they're usually the ones that are most impacted when we think about trying to do preventive work, so we don't have them fit the bracket of adults that need severe care in different areas of health. So thank you.
Thank you, Cynthia. I hope for those of you who are watching on screen, you can see we're adding your comments and additions because we really want to capture them. That's really important. And Anna Ressinger, do you want to unmute and add your comments? If you can't, I'll read them, but you go first.
I am work at an advertising media agency, and we have a variety of clients in public health in different aspects. And what kinds of things can we be doing better I mean, we're constantly part of the, like, working with clients that are either private or in the RFP space, where we're responding to requests from agencies where it's find communities and speak to Californians. And aside from, I mean, we're encouraging, recommending that every video that's created be open captioned, that we provided in every language possible, that you can't just do English and Spanish. You need to make sure that we're addressing all of the languages that you provide services in. But just kind of in that, like, what can we be doing better? And then also in, like, for example, the Solano County example was excellent with the work, and I'm excited to read into that. But like for Solano County, we're trying to do some engagement there, and looking for media or anything that's in language, like what's the best way to reach Filipinos and the Latino community, where there isn't, like Solano, for a media market, it's in between Sacramento and San Francisco. And there's a handful of things, but like it feels sort of, I think it's disingenuous to try to run something in newsprint or even on websites there, where you're totally missing the mark to reach the community. And we want to reach people in language. With advertising, we're not using Google Translate. We're engaging with translators and in community folks from our client side to make sure that translations are correct.
So Anna, that's a great question. And I see in the chat that there's a comment from Maria saying she's happy to follow up in detail. But let me see if anybody wants to add a quick comment to this wonderful point.
Maria.
Can I comment on that, or someone else? I heard someone else.
Go ahead, Sergio.
Yeah. No, thank you so much for Anna, for your excellent question. And there are several things that come to mind. I just to illustrate, in the slide that I presented with the two photos that come from Richland, this migrant housing center, several members of the ethnic media services were there. Sandy Close was there, and some of her team members as well. I was very impressed with them going to people, asking questions, gathering experiences, and they follow up actually with us, asking if they could come to the community clinics that we go, especially in the rural areas, and we had been working on that with them. The other thing that I can mention to you, which has been really an incredible experience for me, is that during the pandemic, I have done media in radio, in TV, and in print media, several interviews. But the one that I want to share with you is the experience that I have had with Radio Bilingüe, in which
they're fantastic partners.
Well, that is great. And what I'm really impressed by what they have been doing for decades is that they open the lines for the audience. And I got several incredible questions directly from the audience, that they were listening, and with some incredibly intriguing, sometimes challenging, but also illustrative questions that they had. So it all boils down, Anna, to listen actively.
Yes.
Thank you, Sergio.
Thank you.
Let me keep us going, because we got a couple more questions in the chat, comments. And Kristen Miller, if you'd come off and add your comment.
Hi, everybody. So my name is Chris Miller, and I'm from University of Virginia. So when Asia was on the line and she was doing her great talk, I grabbed one of the slides that said iterative conversations, many themes. And Asia, I have to go back. You said it so quickly, so I'm going to have to go back and listen to it again. But the way that you switched up how you engaged and asked the question of the community partners resonated immediately with me. Not just, do you guys like this new program that we're putting together? But does it resonate with you? And not yes or no, questions. What's missing? Who's not here? Who needs to be involved? And there were other questions that you mentioned. I'm sorry, I don't remember them all, but the depth and the really kind of the pulling it apart and not being afraid to hear the responses is also. Anyway, I just want to say thank you. That was good.
Asia, thank you. Asia, any comments?
Oh, I'm trying to turn. Okay, there we are. No, thank you. I think those critical questions were really important to getting traction in those conversations. And I think along with that, Kristen, you were starting to get at this, when you hear something about, what's missing, and I know others brought this up in their presentations, but the importance of being able to be flexible and to pivot, because, I didn't mention this in my presentation, but we actually originally started out with the goal of just identifying a set of just 10 questions. So not like the 19 indicators and 4 domains and the whole conceptual model. We set out to develop 10 questions, a Personia set of measures that could be used anytime, any place. And in listening to the community leaders and the larger organizing committee, we learned that this is not what was going to help the field, and this would not be an impactful result. So, listening, but also, showing up is so important. So I'll stop there.
Thank you. And let me point out, this discussion has kicked off a bit of a back and forth in the chat about not everyone knowing how to listen effectively. And Claudia Blackburn, if you'd come off, you've got both a comment and a question after that.
Yeah, I actually have a couple of comments, and maybe they're more practical. But there was a comment about the importance of listening. And I know if you're doing focus groups, people are trained, but when you've got people that are just working out in the community, doing community engagement, you're using students and volunteers and promotoras, and I really think people need training. And I've been in public health for over 40 years and never really had the training that has changed my life until the last couple of years. That was an actual course on nonviolent communication called the Bigby Method that teaches through a practice-based online course to be empathetic, how to listen, and how to express, and all, with it's just a whole system. It's really transformative. And it's just something that it's very specific, my comment, but some kind of training for how to teach people to be empathetic and really listen when they're out in the community. So that was my comment.
A wonderful comment. Anybody want to add to that other than cheers and amens? I think I see Anna cheering. I agree.
And I had another comment as well, but maybe there are others in between. So.
Well, thank you.
Claudia, if I can very quickly mention, the Harvard Business Review has an article that they released, I don't know, maybe a couple of years ago or even less than that, specifically exactly on that question of how to how to listen actively and meaningfully. And if I would love to include it in the resources when we release the resources.
Yeah, absolutely. Yeah,
in
absolutely.
response to your request, Claudia.
Okay, thank you.
And let me add, Kristen Miller put in the chat, academics who want to engage with the community need to know how to listen and know the local history. Name into that. As a very brief aside, at Duke, where I oversaw the medical student programs for a while, folks wanted to go in the community. They had to go get trained by community members of how to act and behave Southern, which was illuminating for many of our students who are from the Northeast. So rather than go into that, there's a great question here. I'm gonna go scroll up again. And I apologize if I mispronounce your name. Is it Yajaria?
Yeah,
Okay, please go ahead.
yes. So Anna, I just wanted to add a little bit about Miriam from Visión y Compromiso. They were sharing really good feedback about being creative and how we write grants to do more of this capacity building and helping community leaders have those skill sets. And often they already do. They're the ones who are the trusted messenger within the community to be part of these projects. That has been one of the biggest takeaways for me in doing more of this community engagement with farm workers in my projects of like the importance of having subcontracts with community-based organizations to be the ones doing the direct engagement. There's so much knowledge and expertise, even the language being one of the biggest barriers for our direct team. But like as we are in a place of an institution like UC Davis, trying to break those like lost connections in the past and like trying to rebuild that trust within our community partners and really like tapping into community-based organizations who are already on the ground. They're the most informed about what's happening and how to be most successful in engaging community. So I would just highlight trying to be creative with how grants are being written and tapping into them being part of the projects and telling us how to reach them directly.
Thank you. And let me add, there are additional comments in the chat about the importance of following up with the discussions and making sure information gets back to the community in ways that are responsive and meaningful to them, and uplifting the community and its members themselves and their institutions to guiding this effort. So let me pause there and just, I'm going to try and summarize the key points, which actually turns out not to be very hard because they're so, the comments are so, they fit together. And then I want to share some resources, and then we have a survey for you. But first, let me thank the speakers, the panelists, and most of all, everybody who participated. This is what some of us call the all teach, all learn. And I think the work of the National Academies has been so, it is powerful because, in fact, under Asia's leadership, the group listened and really brought forward models that were modified by the community, so the community leaders and members, so it really mattered to them. And then you've heard examples of how that work is going forward. But the key issue, I think, is that we're still learning, that this is a journey. It's a journey that has deep roots and has a long way to go, and that communities themselves vary. So it's not a one size fits all. We're needing to modify these issues to fit to build on our community strengths and to help them move forward around their values. And again, communities differ. And that's, I think, one of the lovely things of the National Academies model. The other one that's really clear is that relationships matter. This is being driven by relationships and trust. And that the way we're transmitting this is not so much data and telling people what to do, but it's about stories. And it's about listening to the stories and finding what's common as in our work together to really amplify, build, support the voices of our diverse communities and what they would look forward in health. And I guess my last comment is one of the first things I said is, man, we got a long ways to go. And I really applaud the folks, our speakers, our leaders, for the work in advancing this, but really ask everyone to help us all learn together because it's such a wonderful shift from the idea that the experts have the answer. It's really the experts lie in the communities and in their lived experience and in their wisdom. And I'm really glad, like some of you, I've been in this for a few decades, to see federal and state agencies starting to pick up and support that theme. So please, let's work together to continue this. Let me go to the last slide, which is the resources. Just to point out that much of this has been collected. Ooh, at least on mine. Oh, there we go. We're making things clear. There are a bunch of these resources, and please use them as they're helpful, including the Assessing Meaningful Community Engagement, Health Education Council, Park for Everyone, Vision and Compromiso training, and the Promotoras model, key workforce priorities, and the principles of community engagement with 3rd edition coming. So please use them if they're helpful and modify them as needed. See, did I miss anything? I'll ask our speakers and panelists whether there's anything that they would add, and then to the whole group, were there anything you would add to that summary? And then we'll close with the post survey on time.
Just one thing that I posted in the chat in Anna's in response to Anna's question, the resource from the Harvard Business Review, which is about the power of listening in helping people change. I think that is worth looking at. And Lloyd, if I thank you so much for the wonderful facilitation that you did, and to all the panelists, and more than anything, the whole team behind the scenes that made this possible. You know, Crystal, Maria, Kristen, Vanessa, and others, you know, who participated. And more than anything, to all of you for participating, for being with us for 2 hours. Going back to you, Lloyd.
And last comment is the PDF of the slides, as promised, is in the chat. Please feel free to download it, and we'll be posting the recording of this for those who would like it after the meeting. And thank you again for all your help and wisdom as we move forward together. And one of our traditions is to end on time, because time is so precious. So again, thank you to everyone for participating in this session. The UC Davis, the University of Florida, and guys, may the force be with you.
With you too, Lloyd. Thank you so much.
Thank you, Lloyd. Thank you, Sergio.
Thank
Thank you all.